Hello everyone, my name is Andrea Quicano and I'm currently completing my clinicals at a pediatric rotation located in downtown LA, Los Angeles. And today I'm presenting a case that really emphasizes how we as clinicians must look beyond symptoms to care for the whole person. The topic is pretty common, it is constipation, but as we'll see, sometimes that can seem a little routine. It can also teach us about the value of holistic care, clinical reasoning, and cultural awareness in practice. So, our patient is MG. He is a 16-year-old male Hispanic male who presented to the clinic along with his mother. So, their main concern was that he hadn't had a bowel movement in nearly over a week. He described the discomfort as mainly cramping, bloating, and he also recalled just having a one small heart BM during that time. There was also no history of nausea and vomiting, but you can clearly see that the patient was uncomfortable. So, why this case was so important and why it mattered, it stood out to me the most because constipation is very common, yet it can be brushed off, aside, or minimized by both the parents, the patients, and also the providers. In MG's case, it is very clear that the root cause of the issue wasn't just physical. He was experiencing a lot of stress because of the school finals. He also was reporting that he wasn't drinking enough water. He was also saying that he wasn't eating as normal as usual, and he was eating more fast food. So this meant addressing his symptoms required more than just prescribing a medication. It meant that I had to take a step back and look at the full picture and bringing in a holistic approach. So during the visit, MG reported about 5 to 6 days of bloating with mild cramping. There was no nausea, no vomiting, no bloody on the stool. The usual bowel habits that he will have are usually 1 to 2 every 2 to 3 days. So there was a notable change. He also admitted that he was mainly eating junk food because of the finals. So he was relying on eating junk food, drinking very little water. His sleeping habits were not really the best during this period of time, and also he wasn't getting exercises. The patient's medical history was unremarkable, but there was a strong family history, especially with his dad. His dad has IBS, so it was important that we dig into that and get more information. However, there were no red flags. Like unintended weight loss, having fevers, or any history of recent travels. So the patient's physical exam was very normal. His blood pressure was 112 over 70. His heart rate was 76, temperature was 98.4, and respiratory rate was 16. He was 5 feet 8 inches tall and weighed about 140 pounds. His BMI was 21.3 and he was relatively healthy. The only notable finding was the mild lower abdominal tenderness and hard stool on the exam. There was no rebound tenderness, and because the case was pretty straightforward and classic, no imaging was needed during this visit. Differential diagnosis. So I consider three main differentials for these patients. So the first one would be irritable bowel syndrome with constipation due to the strong family history, but MG didn't have any chronic or recurring pain, which is necessary for me to make that diagnosis. My second differential diagnosis is fecal impaction, which it will involve more severe symptoms or a complete blockage. However, those symptoms were not present at the time of the appointment. And my third differential diagnosis will be celiac disease, which I rule out because there is no history of malabsorption, no weight loss present, and no systemic signs. So, based on the wrong four criteria and lifestyle factors that come into play, my final diagnosis is functional constipation, ICD-10 code K59. So, our plan for MG, it will start with prescribing PEG 3350, which is commonly known as Miralax. I also spent enough time with both the parents, mom and the patient, educating them about how important it is to stay hydrated and also to remain moving and having more of an activity in order to help with the bowel movement activity. Also, we review simple changes like adding fruits, including vegetables, switching fast food orders with things like a salad or brown rice, or just simply drinking more water. I also schedule them to return to the clinic in 1 to 2 weeks and ask them if the symptoms worsen for them to return sooner. Evidence-based practice. So the diagnosis of functional constipation was based on the Rome 4 criteria, which is supported by research included by the Degas article, emphasizing symptom duration and absence of red flags. For the treatment, I chose PEG 3350 as the first-line laxatives because it is safe, effective, and is supported by the NASCA guidelines. It is commonly recommended for pediatric constipation as well works for short and long-term use. Education was also a huge part of our plan. I used guidance from Harvard Nutrition to help the patient and his mother understand the fiber goals, which is generally about 31 grams a day for a kid his age. We also talked about hydration, limiting processed food, and also stress management. We also recommended a follow-up visit in 1 to 2 weeks, but advised them to return sooner if symptoms got worsened. Also, some of the alternatives that I consider include lactulose and magnesium citrate, but based on the current evidence, PEG was the best first step. If symptoms become worse or chronic, we'll reassess for behavioral or specialist support. Holistic approach. For this case, I work closely with both the patient and the mother, making sure they felt heard and involved in the plan of care. Since the patient is Hispanic, I was mindful of cultural values like family involvement and respect for the authority. We talked about realistic changes that they could actually stick with, like healthier fast food options and adding fiber in ways that they wouldn't feel so overwhelmed. I used Watson's curative factors, especially building trust, caring relationships, and showing empathy through our interactions. Overall, my approach focused on the whole person, not just treating the symptoms, but supporting the patient physically, emotionally, and socially for the better long-term outcomes. Conclusion. This case taught me a lot, and it even taught me that the most common complaints, such as constipations, have layers. Layers like emotional stress, environmental habits, culture, all shape this teen's condition. This visit challenged me to apply all the critical thinking skills I have, evidence-based practice. It also helped me getting in touch with my holistic and caring approach, and I left the encounter feeling much more confident that I hadn't just treated the symptoms. Instead, I supported a young person's well-being, and that is by applying James Watson's caring theory. So thank you so much, everyone, for listening to my presentation.